Hello and welcome to today's edition of Patcast. Hope you all are staying safe with your loved ones in this difficult times. Today is May 22, 2020. I am Rifat Manan in Philadelphia, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are excited to welcome Dr. Carlos Parra-Herran, who is Associate Professor of Pathology at the University of Toronto and works as a pathologist at Stony Brook Health Sciences Center there. Today, he will be presenting the second lecture of the GYN PAT lecture series on Patcast. And today's lecture is catered to one of the common day-to-day issues in endometrial pathology for all of us, be a resident or a practicing pathologist. And the title of today's talk is Benign and Pre-Malignant Endometrial Pathology for Everyday Practice. As always, please feel free to post your questions or comments on both Facebook and YouTube chat windows, and Dr. Parra-Herran will be happy to answer them towards the end of the session. Thank you, Dr. Parra-Herran, for joining us today, and over to you now.
Thank you, Rifat, and thanks to you and Emilio for the invitation to talk to you today about benign and pre-malignant endometrial pathology. In this session, we're going to concentrate heavily on biopsy material because that's the most common scenario we're going to encounter these entities. I joined yesterday's session with Fabiola, and I was really excited to see people from all over the world, even areas where this may not be the most convenient time. So we really appreciate everybody that is joining us today. And hopefully this is useful to you. See, I have no conflicts of interest to disclose related to the content of this talk. And as I said, we're going to cover benign and pre-malignant endometrial entities, focusing on terminology and interpretation and reporting considerations. And I said that we were going to concentrate on endometrial biopsies because many people see them as challenging specimens. I can see why. Like they're usually abundant, they're messy, fragmented, full of blood, and interpretation can be difficult. And it may take time to get acquainted to the most common entities. As a matter of fact, there is a reported lack of uniformity in interpretation and reporting of these specimens, and it has actually the highest prevalence of discrepancies amongst pathologists in the spectrum of benign diseases that we see in these biopsies. And that's why it's so difficult to really approach these type of specimens in a standard uniform fashion. On top of that, there are evolving indications and evolving terminology. Currently, endometrial biopsy is really a specimen that is performed mostly to rule out a neoplastic process or other type of anatomic abnormality, like a polyp. And is not needed as much as it was before for functional or physiologic assessments of ovulatory function. Because serologic tests and functional tests have really taken the lead on that. And we need to keep updated in that regard as well. To that end, I just want to say that the Canadian Association of Pathologists a couple years ago led an initiative to update consensus-based and evidence-based terminology for functional or physiologic assessments of ovulatory biopsies, because terminology associated explanatory notes that you have really inserted in your comment section. And we need to keep these two references, look them up, or email me at the end. To that end, I just want to say that the Canadian Association of Pathologists let's start with two examples of endometrial biopsies. An initiative to two examples that consensus-based and evidence-based terminology for functional similarities and some differences of ovulatory biopsies. The terminology associated with explanatory notes that you have really inserted in your comment section. And we need to keep references, look them up, or email me at the end. To that end, I just want to say that the Canadian Association of Pathologists let's start with two first cases today of endometrial biopsies. An initiative to update from census-based terminology for the reporting of similarities samples quite frequent because terminology generally associates with inflammatory are diagnosed and we need to take references and leave them up or emailing at all. To that end, I'm not going to say that Median Association of Pre-Menopausal Case today of endometrial biopsies. The first attempt that I'm census-based quantify terminologies to describe the adequacy of an endometrial sample as inadequate when no endometrial tissue is present. Adequate when you have intact and organized endometrial fragments that contain not only surface but also glands and stroma, and unaccessible or marginal when you only have strips of the endometrial surface or strips of superficial epithelium. So under that categorization, this is biopsy B, where you have in the tissue, but it's mostly cervical squamous epithelium and some densely inflamed, likely cervical stroma. If there is any endometrial tissue here, it's very minimal. And that's when we're dealing with an inadequate sample. So, and the absence or the presence of only minimal endometrial tissue in the specimen always prompts me to say that the specimen by itself is insufficient for pathologic diagnosis. Don't be afraid to say that say so and to recommend repeated sample in these cases. And you can acknowledge the presence of other types of tissue like this is biopsy A, which does have some endometrial lining, but as you can see here, it's mostly strips of surface endometrium. And that's when we're dealing, according to my college, with a biopsy that is on the marginal or unaccessible category. In these situations, adequacy of the sample depends on two things. Depends on the clinical scenario and depends on the amount of tissue itself. In terms of the clinical scenario, we need to be aware that postmenopausal women that have a thin endometrial stripe on imaging will have most likely an atrophic endometrium. And sometimes that's all you get. Sometimes that's all you get is superficial strips of endometrium. In those cases, the sample could be adequate. However, every time you're dealing with a patient that is of reproductive age or has abnormal findings of the endometrium on imaging or has a high BMI, there's a reported, you could say low, but still significant rate of upgrade to a neoplastic process, either atypical hyperplasia or cancer in follow-up biopsy. So in those cases, when the clinical scenario is still worrisome, a biopsy with only strips of superficial endometrium should be considered inadequate and consider repeated sampling. The second element that we look at is the quantity of the amount of strips itself. And I do it based on this very nice study from 2016 that looked at the amount of endometrial strips in biopsies from postmenopausal women. And they found that when it was only less than 10 strips of surface endometrium, the rate of upgrade to a neoplastic process on follow-up was almost 20%. So super high compared to larger amounts of tissue. For example, when there were more than 30 strips in your sample, the rate of upgrade was 0%. Even moderate amounts of tissue, the rate of upgrade was significantly lower. So the amount of surface endometrium that you see in these very superficial marginal biopsies also matters. This is an example of something that was mostly superficial endometrium, as you can see here, mostly strips of epithelium without much stroma, but you can see that the amount of it is really abundant compared to more limited samples. And here, even you can see some fragments with an intact cystically dilated gland and stroma, so that sample was considered adequate. To summarize and to put all this evidence, this is the algorithm that I follow to assess for adequacy in an endometrial sample. Again, if there's no endometrial tissue, that sample is inadequate. If you have only scant surface epithelium or stroma that is highly detached, look at two things. Look at the clinical scenario, and if the patient is premenopausal, in other words, that a patient that should have a thicker endometrium and you should have intact fragments in your sample, or has worrisome findings on imaging, consider that sample suboptimal and mention the fact that there is endometrium, but it's very scant and likely not representative, and suggest repeated sampling. And if the patient doesn't have, or fits the clinical criteria for a thin and atrophic endometrium, look at the quantity, because the quantity can also help you stratify that biopsy as suboptimal or adequate, okay? You can make a diagnosis in a sample that has intact fragments with glands, surface, and stroma. And in that case, you can proceed with a pathologic diagnosis. The last thing I'm going to say about adequacy is the number of levels that we obtain in our endometrial biopsies. And this is a very nice recent study from this year in the International Journal of Gynecologic Pathology, where the authors compared the findings in the first H&E that you obtain from your block versus performing automatic levels from the same block. And the differences, and they observed the differences or significant changes in the information between the first H&E and the two additional levels that they obtained in 0 of their 319 cases. So none of them, the two additional levels, really helped or provided anything else that could be useful or could be relevant for the histologic diagnosis. And this is important because, in these particular biopsies, many places obtain 3 levels or at least 2 levels. My institution obtains 2 levels, but in the light of this reference, we may start considering even that. So food for thought as well for you guys. Now let's talk about the spectrum of entities that we can expect to see in these samples when they're adequate. When I find endometrium that has proliferation, or in other words, mitotic activity in the glands and stroma, these are the 3 terms I usually refer to. It could either be normal, and hopefully we're all familiar with the spectrum of the normal proliferative phase endometrium. The hallmark of it is just the uniformity in the distribution of the glands and in the size of each individual gland, right? That should have visible mitotic activity. If you cut them in a cross section, like in this image, most of the glands are going to look very nicely round, but again, evenly spaced, and the gland to stroma ratio is less than 1 because the stroma still represents most of the surface area in your sample. Weeklyproliferative endometrium is a term that I use when I see an endometrium that, for the most part, looks inactive or atrophic, but I found mitotic activity either in the glands or stroma. And the clinical correlate of that is usually a patient that is perimenopausal or in the early days of the menstrual cycle. As I said, these samples will usually look at first glance as samples from an inactive endometrium or a postmenopausal patient. That's usually the case. Perimenopausal women, you can even see the cystic atrophy here in this fragment, and for the most part inactive. But when you find mitosis here and they're scattered, I usually mention that because it's not inactive anymore, right? There is some weak proliferative activity. This will be the setting where I would use the term weeklyproliferative endometrium. Disordered proliferative endometrium, which we also know as an ovulation or an ovulatory endometrium, is part of the spectrum of unopposed estrogen stimulation to the endometrium. And we can see that in a number of settings: chronic anovulation, like in patients with polycystic ovarian syndrome, obesity, exogenous estrogen administration, amongst others. And there is a spectrum. There is a particular spectrum of morphology that we see in these cases, characterized by patchy stromal breakdown and surface reparative changes. We're going to see this later, but the hallmark is the variation in glandular size and shape with dilated branching forms. This is an endometrium that is going to look proliferative to you because it has mitosis in the glandular and the stromal compartments, but the glands are not nicely round or tubular like in the normal proliferative phase. You're going to see irregularity and heterogeneity in the shape and in the size of the glands. Some are going to be cystically dilated. Some are going to have this irregular branching and convolution to them that are telling you that this epithelium is proliferating, but the shape of the glands is getting distorted because the estrogen stimulation is occurring over a longer period of time than what we see physiologically. In the secretory phase, I usually just use these terms, like it's either a normal secretory phase endometrium, or it has some irregular features, and we're going to dive into this. This is an example that hopefully you can all agree with me. It looks like a secretory phase endometrium. The glandular compartment is a bit dilated with intraluminal secretions. There are cellular changes that also signify secretory differentiation, and here's the stromal compartment. So my question to you at this point is what date would you assign to this particular sample? I'm going to give you another quick view of it. So, these are the possibilities. And if you say B, I don't really care. I probably would side with you because nowadays, and this changes from practice to practice, but nowadays in most practices, this exercise of dating, for lack of a better word, assigning the date of the secretory endometrium is not necessary anymore. For several reasons. The most important one is that this assignment of the precise date during the secretory phase of the cycle to an endometrial sample has at most modest reproducibility. In other words, we're not really good at agreeing what date that particular endometrium belongs to. When we are asked to assign it to a particular day, let's say day 17 or day 18 in the cycle, right? Occasionally, the clinician may request this degree of granularity in our endometrial samples to document a normal progression of the luteal phase. This particularly happens in cases of infertility, but usually documentation of ovulation just is enough when we, or is accomplished when we tell the clinician that you have a secretory sample. If you're dealing with secretory endometrium, ovulation has occurred. And in those cases, staging the secretory phase as early, mid, or late may be sufficient. And this precise dating exercise is not really necessary anymore. Just to go quickly over the changes that we see during the secretory phase, in the first 3 days, the hallmark of the secretory endometrium is epithelial vacuolization that usually starts in an infranuclear location, and in day 17, and the next 2 days starts moving towards a supranuclear location, but it's intracellular. The secretions are still intracellular, and the stroma is indistinct. The stroma is going to look pretty much like the stroma that we see in the proliferative phase. In the middays, in the next 3 days of the cycle, we start seeing extrusion of those secretions into the lumens of the glands, and because of that, the glands are going to look more dilated, more convoluted, the corkscrew appearance that we all know, and we're going to start seeing some changes in the stroma, particularly edema and expansion of the extracellular space, not decidualization, because decidualization is the hallmark of the late secretory phase in the last 5 days, 5 days of the cycle, and where we start seeing this pre-decidualization of the stroma usually starts around the spiral arterioles, and eventually takes the entire compartment. And this is how it looks like, okay? When you see stromal decidualization, even if it's patchy, you know that you're dealing with a late secretory phase sample. This is another example of secretory endometrium that I got in my practice with hysteroscopic diagnosis of endometrial polyp. And you can see why. These samples, these fragments look polypoid. They look very fluffy, but if we look at the cytologic and the architectural features, they don't really look like a polyp. They just look like endometrial, like secretory phase endometrium. This has been described in the literature or by many in routine practice as polypoid secretory endometrium, or secretory pseudopolyp, or functional polyp. This just accounts for the fact that sometimes secretory phase endometrium, because it's fluffy and thick, may appear secretory on imaging or hysteroscopy, but they're not polyps. And my suggestion is to discourage the use of functional polyp or secretory pseudopolyp, because this is just secretory endometrium that looks polypoid. Sometimes I mention the word polypoid to acknowledge, to tell my clinician that yes, it has polypoid shape, but it's really not a polyp. The diagnosis of an endometrial polyp should be reserved to a lesion that is a stromal neoplastic in origin, in which you see variation of glandular size, usually associated with gland dilation. The stromal compartment looks fibrotic, and it is associated with the presence of thick blood vessels. Okay, that should be the strict definition of an endometrial polyp, at least in my practice. I mentioned the word irregular secretory endometrium, which is rather vague, but is something I sometimes use in my practice in the setting of a sample that has secretory features in the glands or stroma that don't really fit within the past physiologic progression of the luteal phase that we described moments ago. Several situations in which this could be the case include disordered proliferative endometrium, or an endometrium with unopposed estrogen stimulation that eventually undergoes ovulation and has superimposed ovulation to it. Some asynchronous patterns and secretory endometrium with premature breakdown. This is an example of a disordered proliferative endometrium. Hopefully you can see, the irregular branching, the tripolar glands that we see sometimes in these anovulatory patterns, where the endometrium is proliferative but is growing in a disorganized fashion. But some of the glands are displaying very, very nice infra and supranuclear vacuolization, indicative of some degree of secretory differentiation superimposed to this disordered proliferative endometrium. In this case, what likely happened was, like, this patient has a chronic anovulation or some sort of unopposed estrogen stimulation, and then ovulation occurs and produces this partial secretory differentiation in the glands. This is an asynchronous pattern. Hopefully you can see that there is some secretory change, particularly the nuclei become round and start being organized towards the base, and the cytoplasm becomes more abundant with ruffled borders. But this is obviously not the architecture of a normal secretory endometrium, because the glands are nice, round, uniform, and tubular, right? And there is some occasional mitotic activity. This is an example of what I would describe as asynchronous endometrium, an endometrium that has some proliferative and some secretory features that don't really fit with any part of the physiologic menstrual cycle, right? This particular patient was on oral contraceptives. So asynchronous patterns, are usually seen in that setting. If you don't know that part of the history, just describe it as an irregular secretory endometrium or an asynchronous endometrium. The only instance where you're going to see secretory changes and admixed with some signs of proliferation is at the day 16 endometrium, or the peri-ovulatory endometrium. The day in the cycle where ovulation occurs, you're still going to see proliferation, particularly in the glands, given the presence of mitotic activity, but you're going to start to see the appearance of subnuclear vacuolization, usually in less than 50% of the glandular elements that you have in the biopsy. That's the only time during this physiologic cycle in which you're going to see mitotic activity admixed with some early stage or early phase secretory changes. I mentioned the word stromal breakdown before because it can occur when it's patchy. It's usually a hallmark of a disordered proliferative endometrium. Stromal breakdown, when diffuse, can be physiologic, and at that point we're talking about menstruation, right, or non-physiologic. Non-physiologic breakdown usually has certain correlates. For example, patients that are under the influence of exogenous hormonal therapy, and eventually that therapy stops, you're going to see diffuse breakdown simulating what happens during menstruation. Patients with intrinsic defects in the normal progression of the cycle, so the predominant follicle involutes prematurely, or the corpus luteum involutes prematurely, you're going to see diffuse stromal breakdown. And the distinction between physiologic and non-physiologic causes can be very difficult, but sometimes it's possible if we have intact fragments of endometrium in our sample. This is an example of an endometrium with significant or prominent stromal breakdown. And the first, and you first think of endometrial stromal breakdown when you see areas of condensation of the stroma. Formations where you see stromal cells that are just too purple, too dense for the normal endometrium, for example, here. And as the stroma condenses, it starts rounding up. And that's what we refer to as the round blue balls that we see in the endometrial samples, or the cannonball formation. The endometrial stroma start condensing, but starts rounding up. That goes along with that condensation. Usually, the surface endometrium kind of involves that round blue ball of endometrial cells. And that's what gives it, in many instances, that very nice round shape to it. Okay, so that's usually what we see in endometrial stromal breakdown: condensation of the superficial stroma with rounding of the cell population. The other feature that we usually see in stromal breakdown is the appearance of accumulations of fibrin, usually within capillaries, but also detached from the specimen, as these specimens usually are. The presence of fibrin thrombi, as in this case, are usually a feature of non-physiologic breakdown. Physiologic breakdown, in other words, the menstrual endometrium, is not really characterized by fibrin thrombi. So when you see fibrin thrombi or fibrin aggregates in your biopsy and it has diffuse stromal breakdown, it's likely non-physiologic in nature. And again, if you're lucky enough to have intact fragments or areas that are not breaking down, you can look at the morphology of those. And if it's not the morphology of the late secretory phase endometrium, then you're probably dealing with an irregular secretory sample or a non-physiologic cause of breakdown. For example, in this case, you see some secretory differentiation, but it's not the secretory differentiation that we expect to see in the menstrual endometrium, because there is no pre-decidualization of the stroma, the glands are not large and exhausted. This is likely a non-physiologic stromal breakdown. This is an example of menstrual type endometrium in which the stromal and glandular breakdown are significant. And if you are lucky to have some intact glands, you're going to see the exhausted gland secretory features. All of these, to say that in reality, when you have a sample that has significant stromal breakdown and it's hard to find intact fragments, the distinction between menstrual endometrium and non-physiologic cause of breakdown can be very difficult. So don't sweat it. In those cases, if I really cannot make my mind, I just call it benign endometrium with diffuse stromal breakdown. If you suspect non-physiologic breakdown because you have proliferative or early secretory changes in your intact fragments, or because you see fibrin thrombi, you may want to mention that in the comment. Regardless, I think it's better to suggest repeated sampling in these cases, because the breakdown is pretty much obscuring every other finding that may be present there. And those patients will likely benefit from a repeated sample outside of the menstrual days. A few words about endometritis. Endometritis can be acute or chronic. Acute endometritis is usually something that we see in the obstetric setting in patients with postpartum hemorrhage and postpartum infection. The term chronic endometritis, which we are, at least in theory, more familiar with, is defined by the presence of plasma cells in the endometrium. Now, I may say that that's in essence the criterion for the diagnosis. However, in reality, clinically meaningful endometritis is usually seen in the context of, yes, plasma cells, but plasma cells in the setting of changes in the stroma and in the glands. The stroma is usually going to look edematous or fibrotic. It's not really going to look like a normal stroma. And the glandular compartment usually undergoes metaplastic changes, usually of mucinous or tubal type. And the presence of plasma cells, it's usually enough that you can recognize it very easily under microscopic examination. One plasma cell usually is not going to make the cut. I've made the diagnosis of chronic endometritis with occasional plasma cells, but in the setting of significant altered metaplastic changes in the stroma and in the glands. If you find an isolated plasma cell in an endometrium that looks perfectly fine, I think the diagnosis of chronic endometritis is really hard to justify. Sometimes you have to hunt for the plasma cells. This is an example of an endometrial sample in which we see some areas of cellularity, and at high power, when you see one, you start seeing them all, right? And in these cases of chronic endometritis, usually finding the plasma cells is not really difficult. It's important to keep in mind that occasional plasma cells can be seen in things that are not endometritis. Endometrial polyps can have occasional plasma cells. Anovulatory patterns and cases with non-physiologic stromal breakdown can have occasional plasma cells. And those are usually plasma cells that you pick up on special stains like CD138 or methyl green pyranine. The take-home message here, or what I'm trying to say, is don't do these stains. If you don't see them on H&E, you do the stain, and yes, you're going to pick up some plasma cells. But if you're seeing them out of context, you may be overdiagnosing chronic endometritis. You need to see fragments of endometrium functionalis that are not endometrial polyp or abnormal endometrial patterns with those typical changes in the glands and stroma to suggest the diagnosis of chronic endometritis. Exogenous hormonal therapy, which is something we see all the time, unfortunately produces very non-specific changes, with the exception of high-dose progestins. And I think we're all familiar with the changes that we see in this context. They can be oral or can be progestins released through an intrauterine device. And those changes are defined under the term that we know as pill effect. Some other types of agents, like progesterone receptor modulators, in Canada we call this Weeklyproliferative, have some less specific changes, but we're going to go over them quickly. This is the high-dose progestin therapy effect. It has diffuse stromal pre-decidualization, which should make you think of the late secretory phase endometrium. But unlike the late secretory phase endometrium, the glands are not large, fluffy, full of secretions. They look inactive. They look very nicely round, small, uniformly distributed. The glands undergo involution under long-term high-dose progestin effect, whereas the stromal compartment retains that pre-decidualized differentiation. These are examples of patients that have been treated with progesterone receptor modulators, or Weeklyproliferative, which is something that, at least here in Canada, is being used commonly to treat symptomatic leiomyomas. In these cases, you're going to see usually a disordered proliferative type of picture with irregularly shaped and convoluted glands. However, when you go to high power, you don't really see much proliferation or secretory activity. You may see mitosis, but they're really hard to find. And the other element that has been described is the presence of ectatic superficial vessels towards the surface. These are the references where you can find these changes. I think they're less specific than the changes that we see with high-dose progestins, for example. But if you know the history of Weeklyproliferative, it could help you understand why this endometrium looks so funny, right? Unfortunately, that's usually not the case. Many times we don't know the clinical history. Other agents that may be present in that clinical history lead to very unspecific changes. Oral contraceptives, corticosteroids, hormonal replacement therapy can lead to the appearance of irregular secretory patterns, disordered proliferative endometrium, atrophy when the exposure is chronic, endometrial metaplasia. You can just describe what you see, just like with endometrial breakdown, with stromal breakdown, just describe what you see, and you can attribute it to exogenous hormonal therapy if you know that such history exists, okay? This is, for example, a patient in which I know there has been chronic corticosteroid exposure, and she was in reproductive age, but has a very inactive endometrial look to it. And before we move into the pre-malignant and metaplastic changes, I want to show you this image of this endometrial sample, very different. And hopefully at this point, I can ask you what would be your next step to reach pathologic diagnosis, or your next step as a clinician. And let me show you the image again. The purpose of this question is very simple because this is the high power picture, and hopefully you saw it at low power. This is fat, this is adipose tissue, which is a really foreign element in this type of sample, right? This little body should not be here. Why? Because the presence of adipose tissue or other extrauterine tissues, fallopian tube, ovary, even ureter, they've all been described. They signify or highly raise suspicion for uterine perforation at the time of the procedure, right? In those cases, the first thing you need to do is review the recent clinical notes and the imaging and review the operative note to see if the clinical team is aware that perforation happened at the time of procedure. And if that's not the case, if perforation with the treating physician is required. Okay, this is one of the few emergencies in routine surgical pathology that we need to be aware of. Let's briefly talk about endometrial metaplasia, which has a spectrum of morphologies. Hopefully we've all heard of these terms before. It's important to keep in mind that endometrial metaplasia is something that happens not only to benign and to the benign or normal endometrium, but also happens in the setting of endometrioid neoplasia. So atypical hyperplasia and even endometrioid carcinomas can have this spectrum of differentiation, ranging from squamous to tubal to eosinophilic and papillary. With squamous, you know, there are some differences, but in all the other spectrums of metaplasia, usually what tells you if it's benign or malignant is the architectural complexity of your glandular population. If you're dealing with simple glands that are not crowded or complex, you're probably dealing with something benign. But if you see architectural complexity, just like in conventional endometrial samples, you worry, okay? In those cases, you disregard the presence of metaplasia, which is probably obscuring the cytologic features, is likely a neoplastic process. Let's quickly talk over this. Squamous metaplasia is usually seen as what we define as squamous morioles or moriolar metaplasia. The moriole in this context is defined as a non-keratinizing proliferation of cells with uniform, centrally located nuclei, eosinophilic cytoplasm, which gives it that squamoid look. Usually occupying the lumens of the glands, okay? And sometimes it may not even look squamous at first glance, but when you go to high power, you see this stratified population of cells that kind of have a streaming appearance, ovoid nuclei, abundant eosinophilic cytoplasm, piling up in a squamoid appearance. That's what we define as squamous moriole. Squamous morioles, particularly in the endometrial biopsy, are important because it's been documented that the risk of subsequent endometrial neoplasia, either atypical hyperplasia or cancer, is low but significant. It's over 10%, right? Even in cases in which you see isolated squamous morioles, the risk of subsequent hyperplasia or cancer is slightly elevated. So if you find a biopsy like this, in which you see a squamous moriole floating around but not associated with a glandular proliferation, you still worry and you still mention it. That risk of endometrial neoplasia, of course, increases when you have morioles that are not associated, but that are not detached, but associated to gland crowding. Because of this, in all these situations, it's better to recommend sampling at the time of follow-up. To exclude the presence of neoplastic process. In other words, if you see squamous morioles, mention it and suggest repeated sampling at the time of follow-up. Mucinous metaplasia is something that we usually see in the context of exogenous hormones, particularly hormone replacement therapy. And mucinous metaplasia, just like other types of metaplasia, are going to obscure atypical cytologic features. And that's why we rely on the architectural complexity. And this has been described like in all the literature as types A, type B, and type C. Hopefully you're familiar with that. Type A is just the simple mucinous metaplasia that is not associated with architectural complexity. Like in this case, you have evenly spaced glands, normal endometrium from the architectural point of view. It just has an area that has very beautiful mucinous differentiation. This is what we will call type A or simple mucinous metaplasia is a benign change. Very different from this, in which you see mucinous differentiation in the setting of significant gland crowding. And as we're going to see in a few minutes, this will qualify from the architectural perspective as a neoplastic or type of hyperplasia type of picture. Eosinophilic metaplasia is very similar to mucinous metaplasia. It also happens usually in the setting of exogenous hormonal stimulation. In this case, the cytoplasm becomes more granular and more eosinophilic, very similar to what we see in the Hürthle cells in the thyroid. And again, what gives it away is the architectural complexity. In this case, we're seeing eosinophilic metaplasia, but in the setting of a markedly crowded and irregular glandular population. Okay, so if it happens in simple glands, it's probably a benign metaplastic process. But if it happens in a crowded and dense population like this, where you're dealing with a hyperplastic process. Papillary metaplasia is usually a benign or reparative process when you see it on the surface. When you see it on the surface, it's going to have this look of micropapillary tufts of epithelium. Usually you see this in the context of stromal breakdown, and is, as I said before, is a reactive process of the surface endometrium. Sometimes you see those micropapillary tufts within glands of the endometrium. And again, if those tufts are short and non-branching, you're dealing with what is called simple papillary metaplasia, which is benign, has a low risk of malignancy. However, if you have complexity to that micropapillary proliferation, you're probably dealing with a neoplastic process, because the risk for endometrial malignancy at time of follow-up is significant. And you can look up this very nice reference that outlines the spectrum of papillary change in the endometrium. For the sake of time, let's just dive into pre-malignant categories. Hopefully, we're all familiar with the changes in the classification that occurred in 2014 and are going to be maintaining in the incoming classification in 2020 and hopefully beyond that. Why? Because it's a much simpler classification. We don't use the term simple hyperplasia or complex hyperplasia anymore. Please stop using those terminologies. Right now, we just pay attention to the presence or absence of atypia. And that allows us to differentiate endometrial hyperplasia in hyperplasia without atypia and atypical endometrial hyperplasia, which is now a synonym of what we've known for a few decades now as endometrial intraepithelial neoplasia, or EIN. There are not different terms or different terminologies anymore. They're synonyms. It's basically the same thing. Part of the spectrum of unopposed estrogen stimulation. We talked about disorder proliferative endometrium before. We know that if the estrogen stimulation persists, that disorder proliferative pattern is eventually going to become a hyperplastic pattern. Eventually, first is a field effect of unopposed estrogen stimulation, but eventually leads to clonal changes in that glandular population. And that's when we're dealing with atypical endometrial hyperplasia. If untreated, it's going to become eventually an endometrioid adenocarcinoma. The main differences between all these terms is basically the degree of glandular complexity. In a disorder proliferative endometrium, you have irregular glands, but the glandular to stroma ratio is still less than 1. In other words, the glandular compartment represents less than 50% of the surface area. And that's the main difference with non-atypical endometrial hyperplasia. You still see the same irregularity and convolution of the glands. And this is something that you see in the entire endometrium. It's a field effect. It's not a localized process. This is something that you see everywhere in the endometrium. But in this case, we use the term hyperplasia because the gland to stroma ratio becomes greater than 1. In other words, the glands represent more than 50% of the surface area in your sample. And sometimes that can be very subtle, like in this case. But if you have the picture in your mind of what's less than 50% of the surface area here in your right, you can appreciate that when the gland to stroma ratio start approaching 1, you're dealing with a hyperplastic process. The difference between atypia and no atypia in the context of endometrial hyperplasia relies on the presence of altered cytology or cytologic demarcation of the crowded population. And hopefully, even at this magnification, you can see that the areas where the glands are not crowded are different from the crowded glands in terms of their cytomorphology, the nuclear size, and just the low power appearance of them is distinct. Now, we know that the definition of nuclear atypia in the endometrium usually signifies the presence of nuclear enlargement, pleomorphism, rounding, loss of polarity, presence of nucleoli. However, it's important to remember that nuclear atypia is variable, and more importantly, that we're very bad at assessing this issue of nuclear atypia. The intra and intra-observer reproducibility of this atypia assessment is very poor, and that's how the EIN model has really helped us in the assessment of these atypical hyperplasia processes, because what's going to help us the most in determining whether something is atypical or not is the comparison with the background endometrium, or with the endometrium that is not crowded. This is an example of that, in which you see an area that is crowded. Gland to stroma ratio is less than 1, very obvious here. But you see glands that vary significantly in their cytomorphology. This is a background gland, and you can see the nuclear size and the nuclear orientation. And this is a crowded gland, in which you can see obvious differences in the cytomorphology. Okay, it doesn't really need to fit that strict definition of atypia that we have in our minds. As long as it looks significantly different, you're dealing with an atypical hyperplastic process. Okay. And that's important because sometimes the epithelium doesn't really look like the conventional atypia that we just described. This is a secretory proliferation. You can see the ruffled borders. You can see the abundant cytoplasm with intracytoplasmic secretions. And look at the nuclei. The nuclei look bland. The nuclei look round, but small, uniform. There's really not a lot of variation in nuclear size. So could this be a normal secretory endometrium? Well, it could be, if we are not aware of the background. Thankfully, in this case, we have the background, and you can see that there is a very nice cytologic demarcation between this crowded area and this area of secretory endometrium. Okay, it doesn't need to be just crowded. It needs to be different from the cytomorphologic perspective compared to the background endometrium, in this case, secretory. So both the native endometrium and the hyperplastic process here had secretory differentiation. A few words about fertility sparing treatment with the few minutes I have left. This is something that we're seeing more and more in practice. Why? Because the incidence of endometrial cancer in young women is increasing. This is already a bit old literature, but you can see that even here in 2014, 2015, about 4 or 5% of patients with endometrial cancer were younger than 40 years old. So there's an increasing subset of the population of patients with endometrial cancer that have not reached their reproductive goals, and they're still in reproductive age. And that's why we have this search of fertility-sparing options, particularly use of high-dose progestins to control this disease. With good outcomes, usually the regression or complete response rate is high, it's about 75%. Unfortunately, this is just a temporary measurement, because with time, the persistence or the progression of the neoplastic process is going to increase. And after the 3rd or 5th year, the rate of progression is really, really high. In other words, this progestin treatment that these patients receive for the treatment of atypical hyperplasia or low-grade endometrial cancer is just a temporary measurement for them to achieve their reproductive goals and become pregnant. And eventually, once those goals are fulfilled, those patients should go for the standard treatment, which is hysterectomy. Patients that are treated with this type of conservative management are surveilled at 3-month intervals with endometrial curettage or directed biopsy, and that's where we come in. And based on the diagnosis of that interval or surveillance biopsy, we're going to be able to determine if the lesion has resolved or has undergone regression, if it persists, or if it has progressed to a more worrisome lesion. Those terms mean different things, whether the initial or index diagnosis was atypical hyperplasia or EIN, or whether the initial diagnosis was grade 1 endometrioid cancer, as you can see here. Now, our role is basically to diagnose what we see. So to make it simple, just apply the criteria that you apply conventionally for the diagnosis of hyperplasia or endometrial carcinoma. However, keep in mind that because this patient is receiving high-dose progestins, the cytology of the lesion is going to change, or has likely changed, and the background endometrium is also going to change, right? How does it change? They're going to see some architectural changes of the neoplastic population under high-dose progestin. You're going to see a decrease in the volume of disease. The number of fragments involved by the hyperplastic process is less. You're going to see decreased glandular crowding and decreased cellularity. You're going to see actually more often cytologic changes, decreased nuclear to cytoplasmic ratio. The nuclei become smaller with some eosinophilia or other types of metaplastic change, right? Secretory, squamous, or mucinous differentiation. This is a sample that was classified as endometrial cancer grade 1, is being treated with progestins. So in this particular sample, we see losses of stratification. This is another sample treated with progestins, and you can see the squamous metaplasia and the mucinous metaplasia that can occur under high-dose progestins. Now, assessment of these changes that happen after high-dose progestins is way easier if you can compare your current sample with the index biopsy, okay? This is an example of an index biopsy in which we have a grade 1 endometrioid adenocarcinoma. This is the cytomorphology of the lesion. You can see the nuclear stratification, the rounding. This is the conventional type of atypia that we see in these cases. This is the 3-month follow-up sample in which you can see slightly lower volumes of disease, but persistence of the architectural complexity, right? It's so much easier when you have the pre-treatment sample to compare. There is persistent demarcation at the cytomorphologic level, and there's persistent crowding. And in terms of the cytologic atypia, it's hard to say if there are changes here due to progestin or not. But when you compare it to the original sample, you can see that the nuclear size is very similar, and there's persistence of that crowding and loss of polarity. So in other words, your diagnosis in this 3-month follow-up biopsy is persistence, or is because your diagnosis is endometrial carcinoma FIGO grade 1, right? Because the volume has decreased, there are probably some indication that there are hormonal therapy-related changes, but because we're at the 3-month mark, this patient should continue to receive hormonal treatment. This is based on literature that shows that the full spectrum of regression, or the higher chances of regression or resolution of the lesion, happen only until you completed 6 months of hormonal treatment. This is the 3-month follow-up sample, and you can see very easily here that the architectural complexity persists. There may be some cytologic changes. You can see here that compared to the index sample, you can see some more organization towards the basal part of the cells and loss of that epithelial stratification. However, the architectural complexity persists, and we are now at the 6-month mark. So at the 6-month mark, we know from the literature that the chances of that carcinoma or that lesion regressing or resolving completely decrease significantly. So at that point, the patient should discontinue progestins in most settings and should undergo definitive treatment. It is very important for these reasons to know the interval between the diagnostic biopsy and the follow-up biopsy. And if you're fortunate enough to have the previous biopsy, compare it with your current sample to make your final assessment. Also look at the background endometrium and report the changes in the background endometrium, which should show changes due to high-dose progestins. If you don't see those changes or that pill effect in the background endometrium, it may signify that the patient is not being compliant with the treatment. If she's supposed to take oral progestins and you don't see those changes, you should mention that to alert the clinician of a possible non-compliance. This is the summary of my talk. Assessing adequacy is the first step that you should always perform when approaching an endometrial biopsy. We saw in this talk that the benign endometrial pathology spectrum is wide and diverse, but it can be simplified and it can have a simple diagnostic approach in most instances. I really commend you to use the WHO 2014 nomenclature for endometrial hyperplasia and stress the importance of knowing the clinical history and comparing pre and post treatment samples in the setting of progestin-treated endometrial neoplasia. With that, I thank you very much for your attention. This is my email. We're going to answer questions now. But if time is not sufficient to answer all the questions, please shoot me an email and I'll try to answer them. Rifat, now to you.
Thank you, Dr. Parra-Herran, for this excellent lecture on endometrial pathology for day-to-day practice. So I have a few questions here. So the first question is from Purnima, who wants to know how to differentiate between normal secretory endometrium and progesterone-induced changes.
By progesterone-induced changes, I guess we're dealing with, I guess she's referring to exogenous progestin, right? So with that assumption, I'd say that if you're dealing with a progestin therapy that is recent, in other words, if the patient has been under exogenous progestins only for a matter of weeks, like let's say during the first 2 to 3 months, more or less, the endometrium is going to look very similar to the physiologic secretory phase endometrium, because both the glands and the stroma are responding to the progestin and are undergoing secretory differentiation. In those cases, I just call it secretory endometrium. And if I know that the patient is taking progestins, then, well, I may make a comment out of it, but it could be very, very hard or even impossible to make the distinction between a normal or physiologic secretory endometrium from that early progestin effect. The good thing is that if that patient continues on progestin treatment, the glands are going to lose that secretory differentiation and are eventually going to become atrophic, while the decidua effect in the stroma persists. And that's going to lead to the appearance of that classic pill type effect, right? And in those cases, you can very confidently say, oh, this is not physiologic, this is not normal secretory endometrium because the glands look atrophic, right? And at that point, you can attribute it to exogenous progestins. Hopefully that answers the question.
All right. The next question is from Ariam. The question is, how do you approach an extensive eosinophilic metaplasia with 1 millimeter architectural crowding with focal nuclear atypia? Would you consider already as EIN or atypical hyperplasia?
If it has all the features, I would. I think it's important for us to pay attention to the metaplasia, mostly because the metaplasia is going to obscure the abnormal cytomorphology of the hyperplastic process. So if it's mucinous or eosinophilic, the nuclei are more likely to look round and uniformly paired to the base, right? So it may not look that worrisome to us. But if you have architectural complexity, if you have crowding, high glandular density, it measures 1 millimeter or more, and if you look at the non-crowded areas and are differences in the amount of cytoplasm or differences in the nuclear size, you can call that EIN or atypical hyperplasia. In other words, rely on their standard features and your standard diagnostic criteria and kind of put the metaplastic changes aside. Because even in those cases with metaplastic or mucinous, eosinophilic, or secretory change, you can tell apart the crowded area from the non-crowded area very easily.
The next question is from Ambarish Padhi. The question is, there is a hairline difference between the atypical endometrial hyperplasia and well-differentiated carcinoma. How to deal with in clinical setting? And he also continues with that. he wants to say that, do we have a tool to differentiate between atypical endometrial hyperplasia and carcinoma, so the surgeon can take a definitive decision like, yeah, or yeah. That's the question.
Yeah. Yeah, I'm gonna try to find one of my figures. I really didn't talk about cancer, but yeah, and I don't have well, I have figures of cancer, so let's talk about that. To me, and this is usually the standard definition, you're dealing with a hyperplastic process, with an atypical hyperplasia, when the population looks crowded, but you can still see the individual contours of the glands. In other words, there are individual glands that are neoplastic and are increasing in number. That's the definition of hyperplasia, right? But there's still some rim of stroma in between. In other words, you can trace, and you can grab an imaginary pen and trace the outline of all these individual glands, and you'll end up with crowded or close together, but still simple glands, right? Like individual glands with a single luminal space, surrounded by a very thin rim of stroma. That's when I'm still at hyperplasia. Okay, when you start seeing, even here, you may see, you still see a lumen and cells surrounding it, but you can separate that glandular structure from the others by a very thin rim of stroma surrounding it. I start thinking of cancer. Let me jump to those figures. I start thinking of cancer when that very thin outline of stroma is lost. For example, here, I know I'm dealing with cancer because you have a lumen here, and then a neoplastic epithelium surrounding it, but there is no stroma at all, right? There's not a thread of stroma that will allow me to separate this luminal space from this one, right? In other words, that glandular population has become confluent or has become complex enough that the surrounding stroma has disappeared, okay? When you see that complexity and that disappearance of the stroma, for example, here you're dealing with cancer, right? Here I can trace an outline across this large conglomerate of glands, right? But you have lumens here and glandular structure here completely devoid of stroma in its periphery, okay? And that's when we use terms as cribiform or microacinar, right? This degree of complexity is what should make you think of endometrial carcinoma, okay? This is when you're dealing with cancer. In an endometrial biopsy, it can be difficult to make this assessment, and sometimes you have very diffuse atypical hyperplasia and then pocket areas of increased architectural complexity here and there, and then you end up thinking, well, should I call it cancer, or should I stay at endometrial at EIN or atypical hyperplasia? Quite honestly, if I see what I do in most cases, I show it to other people to see what they think. But if I'm still on the fence, I would mention it, and I use terms as at least EIN or EIN with foci bordering on well-differentiated endometrial carcinoma, and explain the fact that there are areas with subtle cribiforming and architectural complexity, very worrisome for endometrial cancer. In most settings, the clinician will know what to do regardless of that diagnosis, because the treatment right now, the treatment for atypical hyperplasia and the treatment for a grade 1 endometrial cancer is exactly the same. That patient is going to go either to high-dose progestins or is going to go for surgery, okay? So the treatment is going to be the same as long as you've identified as at least EIN or atypical hyperplasia. That patient should be fine or should receive the appropriate treatment.
Right. The next question is from Daphne. The question is how to word the final diagnosis of a diagnostic biopsy which favors exogenous hormonal therapy, but we have no access to patient information to confirm the same.
Yes, so what I do in those cases is I describe what I see. For example, inactive endometrium, or endometrium with irregular secretory changes, or secretory endometrium. And then I put a note saying that these changes are suggestive of exogenous hormonal stimulation, or these changes could be seen in the context of exogenous hormone stimulation, and clinical correlation is recommended. That's something I've had to do several times because I don't have access to the full clinical picture. But I see that there is something that I cannot explain physiologically, right? So for the typical scenario is the asynchronous endometrium, right? When you see secretory and proliferative features at the same time. In those cases, I just call it irregular secretory or asynchronous endometrium, and then I say in a comment, these changes could represent intrinsic imbalances in the physiologic menstrual cycle or exogenous hormonal therapy, and then clinical correlation is recommended.
So the next question is from Jeremy. So the question is, could you ask the approach to applying EIN criteria in a possible or definite endometrial polyp? And maybe some but not all authorities say that the background polyp is irrelevant to applying EIN criteria. So that he wants to clarify.
Yes. I get that question a lot. Maybe next time I'll include it in this type of talk. It's so yes, when you're dealing with an endometrial polyp, the application of the EIN criteria is a little bit different. The main reason being the glandular population or the glandular compartment of a polyp is going to look irregular. You're going to see a lot of variation in glandular size and shape, and it may look hyperplastic. In other words, it may look crowded. I only have one picture of a polyp, which is really a letdown, people. I'm sorry, but I didn't really think I had to talk about polyps today. Anyway, this is the only picture I have of a polyp. And I just wanted to say that, yes, in the setting of a polyp, you're going to see glands that have a lot of variation in nuclear size and may look crowded. Crowding in an endometrial polyp is allowed. And that's why this assessment of endometrial hyperplasia may be difficult. The main point is when you're dealing with a polypoid with a fragment of a polyp or an endometrial polyp as a whole, your background is the glands within the polyp. Okay. In other words, you look at the glands in the polyp that are non-crowded and compare them to the glands in the crowded area. Okay. If the cytology or the cytomorphology of the glands in the crowded area is similar, not significantly different from the glands that are not crowded, you're dealing with an endometrial polyp, period. It's not EIN, it's not atypical hyperplasia involving the polyp. In contrast, if the cytomorphology of the glandular population in the crowded area is different, if you put them together, not right, side to side, side by side, and the cytology of the non-crowded area is different from the cytology of the crowded area, that's when you're thinking of EIN or atypical hyperplasia involving the polyp. Looking at the non-polypoid background endometrium in that case may be misleading because the glands of the polyp are going to look different from the endometrium functionalis. We know that the glands of an endometrial polyp don't respond the same way to the hormonal background as the endometrium functionalis does. So comparing the glandular population within a polyp with the non-polypoid endometrium may be a little bit confusing and misleading. So just use the glands within the polypoid fragment. Now, that's very easy to say and to do in a single intact polyp like the one I'm showing. It's more difficult to do in a fragmented endometrial biopsy. But those are in principle the elements that I take into consideration. Hopefully that answers the question.
Thank you. The next question is from Bonita. How to differentiate mucinous metaplasia from endocervical gland?
Oh boy, okay, another thing I didn't have time to talk about. Yes, when you have, actually, it's a very important point. When you have, and I didn't mention it, when you have a glandular population in the endometrium or in your endometrial sample that looks mucinous, there are certain things that should come to mind. And probably the most important one is, could I be looking at a lesion from the cervix? Normal cervix usually has a very distinct appearance. It looks mucinous, number one, but it has, if you have stroma underneath the epithelium, the stroma is not going to look cellular like the endometrial type stroma, number one. If it looks cellular, it's going to look cellular because it's inflamed, right? So when you go to high power, you see inflammatory cells, a bunch of lymphocytes, a bunch of plasma cells, sometimes you see neutrophils or eosinophils. So if you have a densely inflamed stroma, it's more likely to come from the endocervix than from the endometrium per se. So looking at the stroma helps a lot as well. And the third feature that I usually see if the mucinous epithelium is from endocervical origin is the presence of a very nice reserved cell layer. And I'm sorry I don't have pictures for that because it will be much easier to explain with a picture. But in the endocervix, usually you have the endocervical mucinous epithelial layer, but underneath it you have a very nice layer of reserve cells that are kind of metaplastic, is part of this metaplastic population of the endocervix that you don't have in the endometrium. In the endometrium, you don't have that reserve cell layer. This is my example of the mucinous metaplasia of the endometrium. In this case, it's very simple, or it's very easy because I know I'm in the endometrium, right? Densely stroma that is not inflamed and non-mucinous glands right next to it, right? So this is a metaplastic process. Look at the absence of that basaloid or second layer of reserve cells in that particular location. The second differential diagnosis that could be coming from the cervix is an endocervical mucinous adenocarcinoma, right? Either of the HPV-related type or gastric type mucinous adenocarcinomas of the cervix that are HPV negative, right? Both can eventually involve the endometrium. In those cases, you need to, if you're looking at something that looks neoplastic, for example, in this image, right? It looks neoplastic and it looks mucinous, right? So could this be a mucinous carcinoma coming from the cervix and spreading proximally into the endometrial compartment? That's something that you should always cross your mind. I've been fooled in the past by thinking that something is endometrial in origin when it was in fact an endocervical primary extending into the cervix. In those cases, usually look for, it could be hard. If it looks diffusely mucinous, I would probably do hormone receptors, ER/PR, because we know that most adenocarcinomas of the cervix are negative for hormone receptors, ER/PR, whereas endometrial hyperplasia or endometrial carcinomas with mucinous differentiation are always positive for hormone receptors, for ER and PR. So that's something that could really help you in distinguishing between endometrial and endocervical. Hopefully that answers the question.
Yeah. No, thank you. Thank you. So the next question is from Schutz. So it's a bit long one, so let me read it.
Yep.
So, in a 63-year-old female, there were malignant cells which were found on ascitic fluid. Immunohistochemistry block that was performed was positive for CK7, PAX8, P53, and negative for ER and WT1. The patient had endometrial thickness of 18 millimeter, which was performed later. So how do you report this? And how would you differentiate serous ovarian from endometrial carcinoma? I hope I could read it well.
Yeah, I think I understood everything. So I'm presuming that that thick endometrium that was seen on imaging was sampled, right? And you're dealing with a malignancy in the endometrium, right? And the question is, could this be, like, how do I distinguish a primary endometrial process versus a process arising from the fallopian tube or the ovary? Now, I'm also assuming that by positive P53, you meant overexpressed or abnormal P53, right? There is some confusion in the term, but usually when somebody talks to me that P53 is positive, I mean, they usually mean that P53 was like overexpressed, was an abnormal P53. In other words, if you
Cells were in acidic fluid, Dr. Parra-Herran.
correct, yes, correct. That was in the acidic fluid, yes. But it's telling you that but if they meant positive P53 as abnormal P53, then that helps, right? You're dealing with a sample that is already in the peritoneal cavity, and it has abnormal P53, likely suggesting that it's a high-grade carcinoma, right? Possibly serous or some other type of endometrial or high-grade Mullerian cancer. In those cases, to address the question, distinguishing between primary endometrial or tubo-ovarian origin relies on two things. One, the morphology, because if it's high-grade endometrioid, for example, is very unlikely to come from the fallopian tube or even the ovary, unless you have a dominant ovarian mass, right? If the ovaries look fine on imaging or intraoperatively, and the fallopian tubes look fine, and you're dealing with an endometrioid cancer, then it's likely endometrial. If you're dealing with a serous carcinoma, then completely different story, right? Because microscopic serous carcinomas can arise from the tube and the ovary and give you the same type of picture. WT1 is probably the marker that helps me the most. If you have access to immunohistochemistry, you do WT1. It's not a perfect marker, but WT1 is negative in the majority of endometrial serous carcinomas and positive in the majority of tubo-ovarian serous carcinomas. So there's been occasions where that helps me. Other than that, you're not really going to go much further than what your clinical presentation is telling you. The clinical presentation that I'm hearing is a patient with ascites and a very important thickening of the endometrium on imaging, right? So at that point, if we are to assume that the ovaries look fine or the tubes look fine on imaging or intraoperatively, in other words, you have an abnormal endometrium and a normal appearing ovaries, that's an endometrial primary until proven otherwise, okay? And I may be proving wrong by looking at the ovaries and finding cancer there or finding a positive WT1, right? But the clinical presentation in these cases usually tells you a lot. The last thing I want to say is that if you have an endometrial sample and you're trying to determine what the origin is, well, pull the block from the acidic fluid and compare the morphology of the two to see if you're looking at the same thing.
Thank you, Dr. Parra-Herran. One last question, I guess that's from Minesh. So the question is how to deal with plexiform tumorlets of uterus and atypical polypoidal adenomyoma in a DNC specimen.
Oh boy. Okay. So a plexiform tumorlet is a smooth muscle proliferation with a funny morphology. A morphology that looks very hypercellular. The term usually plexiform means that it has this streaming kind of palisading morphology to it, but it's a pure smooth muscle proliferation, okay? You usually see that on epithelioid smooth muscle tumors or certain variants of smooth muscle neoplasia that we see in the uterus. In a plexiform, and plexiform tumorlets are usually small. They're microscopic aggregates. An atypical polypoid adenomyoma has a smooth muscle component, but also has a very important glandular component that is usually quite florid, is associated with squamous modular metaplasia, and the glands are typically crowded and irregularly shaped and with areas of high glandular density. In other words, if you're looking at something that has a lot of smooth muscle but has glands admixed to it throughout the lesion, is probably not a leiomyoma, or even is likely an adenomyoma, and you consider the possibility of an atypical polypoid adenomyoma if the glandular compartment looks crowded and looks irregular and looks atypical. Okay, so if you consider the diagnosis of a plexiform tumorlet in a completely different scenario. Adenomyomas could have areas of plexiform tumorlets, but that's usually not the case. I don't remember seeing one in an adenomyoma. It's usually that I see or in the superficial, either in the superficial myometrium or in a pure smooth muscle neoplasm.
Once again, thank you, Dr. Parra-Herran, for this excellent lecture and interacting with the audience. There are a lot more questions, and I'm sorry that we will probably have to stop for a shortage of time. And as Dr. Parra-Herran mentioned, that you can actually reach out to him with your questions directly. You can email him, or you can also ask him on Twitter. He would be more than happy to answer your questions. And I hope he was able to address some of the questions that you asked now. And Dr. Parra-Herran, you would be so happy to know that you had hundreds of viewers from at least 35 different countries. And thanks to all of our viewers for your strong support. And in fact, today I saw for the first time there was someone from Venezuela, Herminia from Venezuela, Vilma from El Salvador. I hope I could pronounce the name well. That is Andrea Mamo Pionona from Madagascar. So thanks to all of you for joining us, and thank you again, Dr. Parra-Herran. And if you like our lectures, please follow and like our Facebook page, that is Pathcast, and also subscribe to our YouTube channel. And if you want to stay notified about the upcoming lectures, you can just click on the bell icon on YouTube channel. It will keep you notified for the next lecture. And actually our next lecture is coming up on Tuesday, that is May 26th. Dr. Ralph Rubin, who is the chairman of pathology department at Johns Hopkins University in Baltimore. So he will be the speaker, and he's going to present a talk on non-neoplastic mimickers of pancreatic neoplasm. And once again, that's on May 26th at 8 a.m. Eastern time, and hope to see you all there. And stay tuned. So thank you again, Dr. Parra-Herran. Thanks so much.
Thank you.